strong number 2 with a market share or market growth better than the market. We have 31 divisions with 23 therapy areas. We have our presence in cardiodiabetic, respiratory, and in acute segment also. So when it comes to respiratory and chest, we do have our 4 divisions, particularly who it's not working, Santosh. So Lupin Respiraveda was the pioneer division when we launched respiratory around 17, 18 years back. Then we had 4 other divisions. Coming to our total field force, we have a medical representative of 6,067 with area managers 11352, regional managers 378, sales managers 93, and national sales head 14. As far as our distribution channel is concerned, which is very, very important, because in COVID scenario, we have seen the company who had been able to, cater the drugs to the different part of the country as well as to the globe. Lupin was one of the leading company who has done it. So that was the reason, sir, India had been, termed as a global pharmacy for India, and Lupin played a very important role. When it comes to our distribution channel, we have 7 central warehouse, 27 state distributor centers, 4,000 wholesalers. We have 7,000 pharmacies and cold chain capabilities. Coming to the Lupin Respiratory as a franchisee, you all know all the chest specialists who have been there in this, those who are seniors particularly. We started with a scratch 18 years back. But then again, we have now near to almost 1,000 crore with a 914 crores of business on the sheet. And we are shortly going to cross 1,000 crores, aiming at 2,000 crores in the coming years. Lupin franchisee today have got 3 major divisions with Lupin Respira, Specialty Care, and Spiritus with 1,000 plus manpowers, as well as we are also aiming to have more number of divisions in the core respiratory also. Coming to our 915 crores respiratory business, we are the second largest respiratory portfolio with 11.37% market shares in overall respiratory, with a market share of 20.1 in the inhalation. Second largest presence in the pediatric segment. We are inching to lead towards the, to have a leader in the COPD with a 66.2% of market share in India-Glyco. The only Indian company which has got a bot for the patients in the respiratory area called Anya. So thank you so much. Thanks once again to the entire faculty, delegates, regional moderators, and the people who have been attending virtually. So may I welcome Dr. Simi from BMJ.
Good evening, ladies and gentlemen. A very warm welcome to BMJ Masterclass on COPD. My name is Dr. Simi Kaul and I'm Senior Clinical Editor with BMJ. Am I audible? Yes. BMJ is a global knowledge provider with the vision of creating a healthier world. We share knowledge and expertise to improve health outcomes. Beyond publishing, flagship journals like The BMJ, Thorax, Gut, and Heart, our expertise extends to medical education, CDSS, which is Clinical Decision Support Tools for doctors, and clinical events like BMJ Masterclass to enhance day-to-day decision-making and healthcare decisions. We'd like to thank Lupin for supporting this educational initiative. Before we begin our scientific sessions, few quick announcements. So you have cue cards which are laid on your table. During the session, we'll request you, if whatever questions you have, please write these on the cue cards and pass it on to BMJ team. We'll address then and there. If there are time constraints, we'll address this after all the sessions are over. Let's begin with our scientific feast, and we'd like to welcome our chairperson, Dr. Jayachandra. He's a senior consultant and interventional pulmonologist, Care Hospitals, Banjara Hills, Hyderabad. He has more than 3 decades of experience in pulmonology, with special interest in interventional pulmonology. He's one of the first to introduce the concept of interventional pulmonology and the entire spectrum of intervention in the country. Over to Dr. Jayachandra.
Good evening, and thank you, Dr. Kaul, for introducing me. And I think we are a little behind schedule. Uh, Basically, we are talking about COPD as a topic, which is of current interest to all the pulmonologists. It forms a fairly large chunk of our practice, and all of us need to be quite updated about the entire disease spectrum and how to manage it. The very fact that there are so many different regimens followed by so many different people itself makes us believe that COPD is not a single disease that, one size fits all. So you need to go into the nuances of COPD, how it affects a person as an individual, and then have a and then you tailor make the prescription or the management for an individual. That is where I think we're going to be talking about various aspects of this particular disease, how to diagnose it pretty early, how to categorize the disease into different genotypes and other things, which is a fairly complex topic. I'm sure our speakers are going to do justice to all this. And then finally, how to manage the exacerbations. I think one thing which has been left out probably quite deliberately is the prevention aspect. The biggest challenge of managing COPD is early recognition so that we can prevent the development or the evolution of the disease so that we do not see such complex cases as we see today. Most of the times, the early cough that the patient presents with is ignored and it is never looked into. So that is where we have a problem wherein people come in with very severe disease. To go into all these nuances, we have three speakers who are well versed in this particular topic, and we're going to talk about them. The international faculty is Dr. Shawn Aaaron from University of Ottawa. His special interest is in COPD, asthma, and cystic fibrosis. He is a pioneer researcher in this particular topic, so he will be joining us online. And we're going to have two more speakers from here who are equally experienced, and I'm sure they'll do justice to the topic that they have been given. One is Professor Salil Bendre. He's from the Department of Pulmonary Medicine of Nanavati Max Super Specialty Hospital. He's the ex-professor and head of Somaya Medical College, Mumbai, and is also the president of Environmental Medical Association. And the third speaker, and not the least, is Dr. Jeenam Shah. He is an international pulmonologist and he's associated with Jaslok Hospital and Saifi Hospital, if I'm not mistaken. Yes. Okay. And he's one of the early interventionalists who has been trained or recognized by the Indian Association of Bronchology. I think I will stop with the introductions here and then go on with the speaker. I think the first speaker would be Dr. Salil Bendre. Yes. Thank you.
Go to the slides. Yeah. Slides, can we go? Yeah, got it. Right? This means this is a pointer.
Yes.
Okay. And for shifting the slides, I just need to press enter. Okay. Fine. Good evening, everyone. First of all, thanks for Lupin and BMJ for inviting me today for this interactive session on COPD. Um, I thank Dr. Jayachandra sir for that wonderful setting up the context of the topic which we are going to discuss today. I can see Dr. Sundrani sir here. He's been one of my teachers during my MD and later on when I was at Somaya Medical College, been associated with him since many years. When, of course, my sir, Dr. Mohanty sir, and he were the ones where I learned the nuances, I can say, of respiratory medicine. And of course, all the eminent delegates here, friends, colleagues. So I'm going to be discussing with you about the early diagnostics of COPD. Now, I'm sure everyone has heard this word right from their MBBS times: asthma, allergies, bronchitis, and COPD. So what's new in COPD is something which we have to get to the bottom of. COPD never ends by just understanding that there is something called as emphysema and there is something called as bronchitis and we should start inhalers. That was what was done many years ago. And that's what is done, unfortunately, even now. But finally, we also know that COPD is a disease which is not a reversible ailment. Once we say it is not reversible, means we have to do something before it starts creating a debility, a disability, or a handicap to the patient. So my talk is virtually going to be just discussing about what can we do to understand whether this person is going to deteriorate further, how can we stop that, and what can be the ways by which we can detect which patient is going to deteriorate a little more faster. So I hope you're finishing your job. Slide changer will be this, but I can see myself on the screen over here. Okay, let's see. So this presentation is going to blow your mind. Okay, that's a disclaimer, because you're going to hear something which perhaps you've not heard. I also took time to read up a lot of things. Now I let me handle it, because if you handle it, it's going to be difficult for me to talk about. Now, time is greater than money. This gentleman, for those who have followed up Money Heist on Netflix, know that he is this character called as Professor. And he is very wise and intelligent, and he talks very sensibly. So time is greater than money. Each of you value your time. I too, BMJ also, Lupin also. So I'm not going to go on talking much about it. So I'm going to put up 3 clinical scenarios. We don't have a polling system, right? We don't have this audience, no, right? Yeah. So in your mentally only you can think about, let's assume that you are sitting in your clinic. You have a 54-year-old chronic smoker. Each of you have seen these patients. It's very common to have a smoker in front of us in our clinic, but he's asymptomatic. He's come to you meeting as a friend, or someone has referred to him to you for smoking de-addiction or whatever reason. He's asymptomatic. He's a 54-year-old chronic smoker. 4 things think of when you go across through this. Will you do a spirometry for this gentleman? Will you start a long-acting muscarinic antagonist or a long-acting beta-2 agonist because he's a smoker? Will you do a DLCO, a diffusion for the lung of carbon monoxide? Or we will not do anything, and we will tell him that if you develop any symptoms, you come back to me. Meanwhile, you practice de-addiction, or you quit smoking, or you counsel about smoking de-addiction. So these 4 ways we can think about approaching this person. Now, each of you are going to think about an answer. Since we don't have the polling system, I'm not going to tell you to vote for the first or the second or third, but each of you are going to be the clinician who are going to see this patient. So think about it, a scenario like this. The another scenario is, this person is asymptomatic, but someone had told him to do a spirometry, maybe as a health checkup, maybe during some pre-employment assessment, and his FEV upon FVC came less than 70%, which is one of the criteria to label a patient as having obstructive airway disease. So he is a middle-aged person. He is asymptomatic at this point of time, but his FEV1 upon FVC is less than 70%. That means it is fitting into an obstructive airway disease. But will you start at this point of time a bronchodilator for him? One. Should we do a HRCT chest for him? Third, will you do a DLCO on him? Or should we say, okay, now that you are asymptomatic, since you don't have any symptoms, why should we do anything? You can rather do a spirometry again after 5 months or 3 months or 6 months. Come back to me. We will see if there is a decline in your lung functions and then decide about starting some inhaler or a bronchodilator. Okay, so these are again 4 options in front of you. Try to understand what you will be doing. Try to think about them, because over the period of the next 15 minutes, we'll try to find out whether we are in the correct line of sequence or not. Right? He's asymptomatic, but the FEV1 upon FVC is less. Now we have a 48-year-old patient. Okay, all of you have again seen this, or maybe you'll be seeing them in the next few weeks or months. You have a patient who is a symptomatic smoker. He has cough off and on like a smoker does. He gets exertional breathlessness, mild exertional, not very severely breathless. You did a spirometry, it came normal. So as per the spirometry report, it is not fitting into obstructive airway disease, but he is symptomatic. Will you label him as a COPD because his FEV1 upon FVC was less than 70%? Will you start him on a bronchodilator? Again, that question is there. And will you do a DLCO in him? So how much importance do we give to DLCO is what we are trying to see at this point. Or should we do everything? Do a DLCO also, call him as a COPD patient. There is no reversibility. I am telling you this. The FEV1, FVC is definitely normal. So we can't really think about a reversibility at this point. So will we do this of one of these 4? So these are the scenarios which we are going to think about. And if we think about them, then we have to also understand how did it come to all these 3 cases. First patient, he is a smoker asymptomatic. Second patient, he is a smoker, but the FEV1, FVC was less than 70%, but asymptomatic. And this person is symptomatic, but normal. So we have to go back to understanding what exactly happens in this ailment called as obstructive airway disease. When we say obstructive airway disease, I always start off that the lungs start from the nose and it ends at the alveolus. And the airways conduct the oxygen. And that is where the obstruction happens, narrowing happens. But it's most often because of smoke. Now, when we say smoke, it's the environmental tobacco smoke. It may not be active smoking. It may be biomass, gas exposure. It may be the pollution, indoor exposure, many things which can aggravate a smoke-induced problem. Even incense sticks, the agarbatti or the puja, the havan, all these things are inducers of causing oxidative stress, leading to perforins and granzymes. So these are the things which happen at the level of the physiology. We have just discussed the symptomatology. All those 3 scenarios were about symptomatology. But we are talking of what happens before that. So the physiology. And if today at this point of time, we are thinking of October 2022 and discussing COPD, please remember that it was 1679 that the first time a disease having hyperinflated lungs was first told to the world. 1679. You can imagine how early that concept had evolved. And then it was, of course, in 1814 where the beginning of understanding of chronic bronchitis came into existence. And then Laennec, 1821, the one who invented the stethoscope, he was also the one who actually described what happens in COPD. You see, the genesis of COPD is not about what was mentioned in Harrison and how it evolved. The genesis has been so much ago, long ago. And here today, we are still talking about how to diagnose it early. And of course, Oswald and Bickerman. So many things in history. So history is important, no doubt. We sometimes ignore them. We don't reflect back on history. But since we are talking of BMJ and we are in Mumbai, I need to mention about this wonderful character which has grabbed everyone's attention. Okay? Because that word British Medical Journal and talking of the British Prime Minister, it's very important that we should understand that today we both, our country and the other country is equally important. And perhaps we may get back the Kohinoor at some point of time. Okay. So coming back to COPD, two landmark meetings, the SIBA Symposium and the American Thoracic Society, they talked and defined what exactly is COPD all about. And that's where we are coming back to the natural history of COPD. So if you even think about this, let me see if I can. Now, this is where each of you have seen your patients, you or yourself. You have seen your patients at this juncture. You have not seen the patient at the juncture where physiological alterations have happened, and neither have you seen these patients where the biochemical and cellular events have happened. And once this happens, he has passed from the onset a significant amount of duration or time. And that time we say, oh, now you have developed a COPD, we should start bronchodilators, we should start pulmonary rehab. And we very well know that it's not much of a life left for him after that, at least not a healthy life left for him after that. So let's come back to next couple of slides talking about the importance of early diagnosis. So this was very interesting, though it appears too much of an informative slide, that 70% of those with undiagnosed airway obstruction and up to 50% of undiagnosed COPD denied having any cough or phlegm and denied having wheezing. So this is a huge number of people who were surveyed. They had obstructive airway disease, but symptomatically they did not mention the typical symptoms which we characteristically talk in terms of COPD, of cough and wheezing and phlegm. Okay, that was a significant number of patients. So remember that symptoms are not the only means by which we should suspect COPD. It could be a later on event which is happening. So all those patients whom you have thought about, symptoms to nahi hai, khansi nahi hai, breathlessness nahi hai, they must not have developed obstructive airway disease. We may be some way missing an early diagnosis of COPD. Also, among subjects with severe airflow obstruction, a substantial proportion did not report symptoms. This is again a longitudinal study of over 2,000 patients, and again 20,000 people, 8% were found to have COPD, of whom 35% had no symptoms. So the norm which goes by that symptomatic means we should treat. Somewhere maybe we are actually missing the boat and we are going ahead not understanding that these patients could be developing COPD. So what is this early COPD? My topic is actually early diagnosis of COPD. So early COPD thinks about a post-bronchodilator FEV1 about FVC is lesser than normal, that is a lower limit of normal. A CT scan picture is something which is important if you want to think of an early diagnosis of COPD. Okay, it may happen and we may think that, oh, this patient is like a COPD. What is the role of a CT scan in this person? वैसे भी मैं inhaler ही देने वाला हूँ, वैसे भी मैं vaccinate करने वाला हूँ, वैसे भी मैं pulmonary rehab बोलने वाला हूँ. So what's the point of doing a CT scan? But no, early diagnosis implies we should be paying attention of doing a CT scan. And evidence of accelerated FEV1 decline. Okay, this is again very important. That's the place where we have repeated spirometries to know whether there's a decline in the FEV1, and that could be a pointer that this person is actually going to develop a permanent disability with airway obstruction. Now, the unfortunate part is we do not have exact biomarkers that allow us to differentiate between a COPD phenotype with worse progression and those with benign courses. So we will never be able, at least at this moment, we don't have those biomarkers. So if you have two patients, same age, same number of cigarettes, we never know which one will decline faster and we never know which one will decline slowly. So that's a hitch which we are facing. So early diagnosis has many interpretations. So if I put a question to each of you, what do you mean by early diagnosis? So a lot of pulmonologists for that matter say early diagnosis is diagnosed before the beginning of symptoms. So there could be no symptoms, but you have done a spirometry, it shows airway obstruction, FEV1 by FVC lesser than 70%. But the first example, or rather the second example, was that the FEV1 FVC was also normal, but he is a chronic smoker. He may be a smoker, but yet not developed a physiological entity or a change in the obstruction. Should we start treating them? Should we consider this patient as COPD in the early phase? Now, another important group is what we call the gold guidelines, the gold zero. Now, gold zero is defined as individuals exposed to the risk of COPD. You think of all your friends, neighbors who are exposed to the dust exposure or smoke exposure with normal spirometry. So normal spirometry is also included as a part of COPD and having chronic symptoms. And the risk benefit of identifying this group in the population must be individualized, and therapeutic strategies should include non-pharmacological measures. So at this point of time, what the guidelines says, non-pharmacological measures. So it could mean, of course, avoiding the smoke exposure. It could mean rehabilitation, breathing exercises, but they have not commented on the pharmacological aspect of treatment. So we have got early COPD and mild COPD. So early COPD emphasizes capturing early phase disorders in high risk individuals before the FEV1 FVC ratio falls. Correct? Now, what I have read when I was doing my MBBS or MD is chronic bronchitis means cough with expectoration for 3 consecutive months, 2 consecutive years. And emphysema is permanent and irreversible dilatation because of the loss of the elastic recoil. And then came in the guidelines which insisted that FEV1 FVC less than 70% and poor bronchodilator reversibility. If that is there, then this patient is labeled as having COPD. So we have got certain parameters which can actually help us. Okay, go back to your patients who have come to you. You have not investigated in terms of doing a CT scan. Since they were asymptomatic, you probably thought they may not be developing COPD, and you have just told them about de-addiction, but they could be declining more rapidly. So if only one of the criteria were used, 3 criteria for early COPD. One was, of course, the spirometry criteria. Second was the CT scan criteria. And third was the rapid decline. So even if only one criteria was used, the prevalence of COPD was 7%, 10%, and 15% respectively, even if one of the criteria was used. So imagine if you use all the criteria, then it would increase the number of early COPD patients, which we are going to see. So I will come to the 3 investigations which have been proposed or which have been studied to diagnose early COPD. Okay, so of course the gold standard of COPD diagnosis rests on the forced expiratory volume 1 per second upon the FVC. So one of the criteria which has been studied is about the slow vital capacity. If you ever see your spirometry results and reports, and if you have a slow vital capacity done, then the ratio is a better marker of talking of early mild obstruction. Okay, but the problem is we don't have reference values for that. So it is not a very, very often done test, or it is not standardized. So we are not going to talk much on that. But trust on me that maybe in the years to come, this is going to be one of the parameters which we may think of to diagnose or to think about early COPD in a patient who is a smoker but asymptomatic. Okay, we may have to think of this. There is one more interesting parameter called as the forced expiratory volume in the 6 seconds. So if you have understood the spirometry maneuver, it is taking a deep breath. The person is told to take a very deep breath and exhale forcefully for at least 6 seconds. Now, when I talk about airflow limitation, you imagine that the airways are narrowed and he's trying to exhale. Because the airway is narrowed, he's unable to exhale all the air in 6 seconds. He's going to take a longer time to exhale all the air. And that entire air to go out will be the forced vital capacity. Now, generally, it is corroborated that the 6 second FEV1, the forced expiratory volume in 6 seconds will be equivalent to the FVC. This is understood because we are doing a maneuver and in 6 seconds, we have to take it as a guideline to see the ratio. So if we apply FEV1 upon FEV6, not the FVC, the FEV1 upon the FEV6, it is a better parameter to actually diagnose early airway obstruction. Now, certain machines, certain spirometry instruments have a value of FEV6 incorporated even now, but we don't have that standardization to talk about as a criteria in terms of guidelines. The guidelines still mention about the FEV1 upon FVC, but there are now enough studies, enough data to talk about FEV1 upon FEV6 as a very interesting parameter to understand about early COPD diagnosis. And I will not obviously go into all the studies, but even it has been seen in the GOLD guidelines, a mention of this about the ratio of FEV1 upon FEV6 less than 0.75 instead of FEV1 by FVC less than 0.7. So if you talk about this, it is definitely a parameter which is going to help us all. Maybe after 4 years, BMJ will do another such program. Lupin will again be supporting it and everything. And there will be someone like me standing here and telling you that now the GOLD has changed the guidelines or introduced newer guidelines to diagnose early COPD by taking into consideration the FEV1 upon FEV6. It is definitely going to come because these are the studies which have been authenticated in many of the slides and many of the studies, and they have shown to be important. So it significantly associated with the CT scan changes also, air trapping, small airway obstruction, emphysema, which have not been evaluated on X-rays. You need to see that there is a lot of corroboration with that. So we have to consider that certain investigations like Dr. Jayachandra was also mentioning, and the earlier speaker was introduction was talking about, Hirak was rather talking about introducing the lung oscillometry technique is coming up very rapidly now. So in people who are unable to perform a spirometry maneuver, people who are coughing, people who are hypoxic, and we can't really tell them to do a spirometry maneuver, a lung oscillometry is going to be changing the entire way we look at obstructive airway diseases. And in Mumbai, at least, we have got a good number of centers. In fact, the pharma is also, Lupin is supporting a lot of pulmonologists to get this investigation done. Last couple of slides now. One is about the DLCO. So it is a very important test, especially because we are going to talk about the diffusion of the lung. So adding the diffusion capacity measurements can detect earlier abnormalities in the small airway disease, even before there is a change in the FEV1 upon FVC. So please consider that if you have a patient who is a smoker, and if you do a spirometry and his values have come above 70%, don't hesitate to not advise a DLCO. You may actually find that the DLCO is reduced. And if you repeat a spirometry after 1 year, at that point, not only the DLCO is reduced, but also the FEV1 over FVC has reduced by that time. Because he started showing up the airway limitation by that time after 1 year. So DLCO is one thing which will help us in understanding the concept of early COPD. So this particular study was done in smokers, and they found that there was only 3% developed COPD compared with 22% in the group with normal spirometry but low DLCO. So they had a normal spirometry but low DLCO. So that is one group which we should be considering. CT scan I have already mentioned, very important, and you need to assess that. So the last 2-3 slides now. This interesting study about the spiromics, it showed that respiratory symptoms were reported by 50% of current and former smokers with preserved pulmonary function tests. So again, symptoms are not the basis on which we are going to only think of COPD. We need to put it along with FEV1, FEV6. If possible, we are going to take help of a CT scan. We are going to take help of a DLCO. And perhaps even a 6-minute walk test. Even that would tell us about the airflow limitation or the diffusion which is getting affected before actually he develops moderate COPD or a severe COPD. So the development of airflow obstruction indicates an already established disease process, and this has implications for potential of treatment. And the take-home message from all this, just as a precursor towards the next talk which is going to happen, is small airway disease is definitely the beginning of early COPD. We need to understand whether pharmacological therapies are going to change the outcomes of the diseases, of this particular disease. Are we going to improve their quality of life and avoiding or stopping from them becoming a cripple? So we have now COPD as a disease. We talked about the history, that was the past. We are present in the scenario where we are discussing the present of what can be done. And of course, there is always a future. So the past is different, the present is different, and future could be something different. The future is something which we can change. This is not actually, I hope it's not the way the future develops, but same, I don't hope that in COPD also the future develops in such a bad shape. But the future of our patient depends on how we have managed to have an early intervention, early diagnosis, early therapeutics. And therapy doesn't mean only pharmacotherapy. Even if you have one step ahead, you put a one step ahead to start rehab earlier, to vaccinate the patient earlier, to keep a watch on the decline in the FEV1, not just label normal spirometry, that's okay. No, don't do that. We need to have a serial spirometry evaluation. Take help of the CT scan and phenotype these patients so that you can actually decide the pharmacotherapy in a better fashion. So with that, I can just say that words are so futile and feeble, but words matter. And you all are such a lovely audience and beautiful people. So thank you so much for a patient hearing. And thank you again, Lupin and BMJ, for inviting me today. I would request the moderator to please go ahead. Thank you so much.
Thanks, Dr. Bendre. There's only one comment that I need to make. I think he's emphasized enough on the early diagnosis of COPD. Only one factor is spirometry itself. Make sure that the spirometry is done properly. This is the biggest issue that we face in the real world in our country. None of them are standardized. Make sure that you're getting it done at a place which knows how to do it, and it is frequently calibrated. I think that is the most important message that needs to go out among the pulmonologists. Don't accept any nonsense which is printed and given to you. That is point number one. The second thing is FEV1 by FEC6. COPD patients generally can keep on blowing out for almost 11 to 12 seconds. So 6 seconds is a cutoff point for severe COPD, and that's where it comes in. If the FET is less than 6 seconds, please don't accept this spirometry report at all. I think I'll stop here. This is the only comment I wanted to make. I think I'll ask Jeenam to go on.
No, this just comment extending on that. That's an absolutely valid comment about spirometry. It's not a report which should be seen as a computerized report which comes in and says that this is obstructive or restrictive. The technique matters, interpretation matters. And if our base is based on the spirometry values, and we are going to monitor that, I think, sir, your comment is absolutely precious for that. So we need to take that as a very important remark. Thank you.
A very good evening to everyone. First of all, I would like to, thanks BMJ and Lupin for inviting me over for this talk. Talking about COPD, it was a wonderful day for me today. Today morning, actually, we had one patient who had come from all over interior Maharashtra. Patient came with stridor. Patient had severe breathlessness. She was a young 27-year-old female. She was actually 7 months pregnant. She had been treated in the interiors for query COPD, query asthma. She was on multiple nebulizers, inhalers, not getting better. Ultimately, she came into a stridor state, presented to our hospital. Retrospectively, we realized that actually she had a postglottic stenosis long time back, 2005. She had a stent in situ, a silicone stent was inserted. Subsequently, we had to, do an emergency rigid bronchoscopy, remove the stent, core out that entire granulation tissue which had accumulated distal to the stent. So idea of talking about that thing today is that, not all those visas are actually asthma or COPD. You need to start thinking much more beyond it also. So today my talk is going to be phenotypic of COPD. We all know that we have a lot of phenotypes in asthma. We had not been discussing that, but there are a lot of COPD phenotypes also, which has not been emphasized up till now. And the second part of the topic would be a gold classification of how to group your COPD patients into. So first of all, very happy Diwali. Everyone would have enjoyed it. This is actually where I live. This is somewhere on the Marine Drive. And this is the hospital where I work. That is Saifi Hospital. You can see there are a lot of firecrackers which are burning, and in this, you can see actually people, this is an actual photograph. People are actually wearing a mask and bursting firecrackers. So they are very well aware that it is going to cause a lot of pollution. But in spite of that, we are not going to stop bursting crackers. We are going to wear a mask, thinking that just while wearing a mask, I'm not going to get exposed to all those pollution. But unfortunately, we all have seen that in our practice, post Diwali or during Diwali, we have a lot of patients of asthma and COPD who come into an exacerbation, which is absolutely not the correct thing. We need to, have a pollution-free Diwali. Light is the only thing. We should definitely avoid bursting crackers. The same situation was there in Delhi also, where I was studying. Same thing, people are bursting crackers all across the road, but they are wearing a mask, thinking that, I'm going to be absolutely safe. So the fact is that exposure to PM 2.5 lead to 4.2 million deaths and 103.1 million disability worldwide. That is the 2015 data, and accounting for 7.6% of total global deaths and 4.2% of global dailies. That is disability limited. So that's a huge number. 7.5% is a huge number. Coming to today's talk, it's going to be divided into two talks. First is going to be about COPD and the phenotypes. And after that, I'm going to be talking about the classification of gold grouping, that is ABCD. So COPD is a very complex disease. Complex means that COPD has a number of intrapulmonary and extrapulmonary components. So in COPD, we are not just talking about the airways. We have a lot of extrapulmonary components because apart from the lungs, you have heart, you have kidneys, you have all the other organs getting involved because of COPD inflammation. And it also means that it is heterogeneous because all these components are not present at a single time. You have some component present at some time and you have the other component present at some other time. So it is a heterogeneous disorder. And this realization will help us personalize the treatment for COPD later on. So right now, what we are at this stage. So we know that every people of COPD differently behaves. Some people have some other symptoms, some people have some symptoms. So what we are trying to do now is to phenotype those COPD patients into different groups. So see that blue color group is something like a chronic bronchitis, or some other group is like an emphysema. So we are at this stage where we are understanding how to phenotypically differentiate each patient into a different category. But that is not going to be the end point, because we need to actually select a subgroup of patients which a particular modality of treatment is going to work better than the other modality. But in actually a reality, what you find is you cannot easily group them because every patient will have a different disease at different point of time. So that is why it's not as simple as we feel that phenotyping of COPD, we are done and a particular subgroup will get a particular treatment. It is going to be a heterogeneous population. So we have to realize how to, personalize the treatment into a particular category. So this is a graphical representation that, a lot of people get exposed to smoke, not just smoking, that is chulla, that is pollution, but a genetic factor plays a very important role, leading into different types of inflammation, thrombosis, fibrosis. And ultimately what we see as a clinical status is actually nothing but a combination of epigenetics and an environmental factor. And then the patient can have different subsets of COPD. So there are a lot of genetic factors also which play a role, and it is not just the smoking exposure that is going to be there. A wonderful diagram which presents this is this. This is by study et al. Published in NEJM 2014. So what they did is they saw the patients of COPD and they retrospectively saw their lung functions. So what they realized, there are 4 groups. The 2 groups which are at the top, which developed complete lung function. That is, their FEV1 was normal at the time of adulthood. But there was a different subset that is didn't develop normal lung function. So their FEV1, if you see, started off only at 70%. So what happens is, over a period of time, when you see people who are smokers or are exposed, they had a rapid decline and they developed a COPD. But people who had normal decline did not develop a COPD. But at the same time, people who had childhood problems like childhood exposure, childhood infection, some disadvantage during the childhood, what happened, even a normal drop of FEV1, they still develop a COPD. So what we say is that, COPD is only happening in smoker. We are not realizing there are a lot of genetic factors, childhood factors, which come into the play and which is leading to COPD. So this is a very good presentation that, actually they found that 50% of people who develop COPD was because they didn't develop the normal lung capacity in adulthood. So 50% were smokers and exposure to chemicals, but rest of the 50% were childhood people who didn't have good lung capacity. So our understanding of dynamics, it did not change. The slides have not changed. There's some hang. Really sorry for the delay. But this is not changing more. दोनों जगह पे change. So till the time he settles it down, so our understanding initially, if you known that the gold guidelines, when it initiated off this, the entire crux of the matter was FEV1. All the classification, whether it is 1, 2, 3, 4, was all based on the FEV1 values, whether it is 80%, 50%, and 30%. But as and when, we have realized that COPD is different. All people have different tendencies. We see a lot of patients with FEV1 of say 40%, but they're absolutely okay. They don't have any problems. They do not have any exacerbations. But at the same time, we see a patient who is having 70% or 80% FEV1, still having a lot of exacerbations, coming to the hospital recurrently. So that is why the understanding needs to change. We do not have to rely just on an FEV1. We have to rely on much other factors. That is why the gold guidelines, if you see, the last 2011 onwards, they have started dividing that COPD into A, B, C, D groups, where you don't see just the FEV1. What you're seeing more is the symptom risk. So what is the symptomatology like? Whether I have too much breathlessness, what is the MRC grading? What is the CAT score? That will tell us what is the symptomatology like. At the same time, we see the exacerbation risk, because ultimately, what do I want? I want my patients to not have recurrent exacerbations. I want my patients to have a healthy lung capacity, which is persisting, because we know every exacerbation will have a drop. So that is why now the exacerbation risk plays a very, very important role in categorizing the patient of COPD. Still not working. But it's not. Okay, slide. Okay. So that is why our understanding has changed completely from just an FEV1 dependent PFT. Now we have more into a complex situation where we personalize and we phenotype the patient into different subtypes. Okay. This is again not changing. It will only change through here. Okay. So this is the first guide. I mean, this is not the first. This is the 2006 guidelines, which says that it is just on FEV1. But now we have the 2011 guidelines, which says that we divide into A, B, C, D depending on the different groups and different symptomatology. So initially it was again one size fits all, that everything has to be, if it's gold group 1, then you have to give a particular treatment, or gold group 4, you have to give ICS and all those things. Now we are moving into a more personalized medicine. So what is the concept of phenotype of COPD? A group of experts proposed that a physical appearance or biochemical characteristics as a result of interaction between a genotype and an environment. So that is why you define as a COPD phenotype. So it is the genotype as well as the environment which comes together to develop ultimately a characteristics. important thing is we just do not want to subgroup based on a particular thing. We have to actually have a meaningful impact so that we can differentiate the treatment aspect of every patient. So there is no consensus on the number of phenotypes, not just have biological or epidemiological sense. We have to prognosticate and therapeutically use it for further treatment. So there are two subsets. One is the classically COPD subtypes, and second is the new COPD phenotypes. The classical one we have already discussed is the chronic bronchitis and emphysema. Bronchitis is more than 2 months, 3 months of cough and sputum for 2 consecutive years, and emphysema is when you have destruction of the alveoli beyond the terminal bronchioles. This was in the past, but then ultimately they were combined into a COPD subset, and it was also sometimes labeled as pink puffers or blue boaters. Now, what are the newer COPD phenotypes that we recently see? The frequent exacerbators. In spite of having a FEV1 which is near normal, they have frequent exacerbations. The fast decliner, you will see that every yearly there is 100 ml of drop of FEV1. Those are also different subsites. Inflammatory phenotype, current smoker phenotype, systemic or comorbidities. You see a patient of COPD which has a lot of comorbidities. IHD, you have kidney issues, you have cancers, and you have a lot of other problems also. So every patient will have a different phenotype. If you actually go back and start looking at your COPD patients in a better way, you'll realize that every patient will fit into some of the other phenotypes that is not it's individually different. So emerging phenotypes is pulmonary cachexia, also one of the phenotypes. Then we have the COPD and the bronchiectasis. A lot of times you see a CT scan, you find out there are some bronchiectatic patches in each of the lungs. Then you have the comorbidities that we have already spoken about, and then we have a non-smoking COPD. We see that patients who are not having at all smoking history, but because of whatever pollution or some other gases exposure, they develop COPD. I'll just skip through that. So now we'll go into individual, that is systemic COPD. That is a spillover theory. So you see that there are a lot of inflammation which is there in the lungs, which ultimately spills over through the circulation into different organs, which leads to different kind of cardiac. Cardiac is the most studied phenotype. But apart from that, you have lungs, you have muscle involvement, you have psychiatric involvement, you have a lot of other cardiovascular morbidities which comes across. And then we have the COPD in biomass exposed non-smoker patients. What is different in them? That you see a lot of patients who are younger age. You see a lot of females who are actually working in rural areas using that wood chilla. You see that most of them are younger age, and most of them have a lot of small airway involvement. At the same time, they have a lot of features of chronic bronchitis and bronchial wall thickening, which is the most common thing. And they also have recurrent exacerbations and frequent hospitalizations. So that is a different phenotype where they have recurrent exacerbations, small airway disease, but the relatively preserved FEV1. So then you have a systemic inflammation of the COPD and smoking. So this was a very important study which was done, which tried to assess what are the inflammatory markers in COPD. So what they had done is they had divided into non-smokers, smokers, and COPD patients. So what they found out is in a non-smoker population, all the inflammatory markers, that is WBC, CRP levels, TNF-alpha, IL-6, and fibrinogen, very few patients of COPD had those kind of raised inflammatory markers. But when they studied the smoker patients, they found that there are very high levels of inflammatory markers, WBC and TNF-alpha and IL-8. But when they studied the COPD subsets, to their surprise, they found out that not just the smoking-related biomarkers were increased, a lot of other biomarkers were also increased. So then they realized that there is not just the smoking-related exposure which is causing this problem. In general, COPD patients have a lot of inflammatory damage which is going on inside the airways, which leads to a lot of inflammation and subsequently COPD. And that notably, these patients had frequent exacerbations and 6 times higher mortality during the 3-year of follow-up. So it is not just the smoking-related inflammation, it is inflammation because of other substances also, which is causing the COPD and which is leading to a lot of problems. Then we have the frequent exacerbator. Again, these are moderate and severe exacerbations that you count is when they require a hospitalization or where they require a dose of corticosteroids or antibiotics. They have more airflow limitation, they have more symptoms, and they have more of health-related life impairment, and they have worse prognosis. So that is when we have to start thinking whether this subset, that is inflammatory subset or patients who are having frequent exacerbators, do we need to treat them differently? Because as of now, what we have is, we are treating them more or less in a similar way. We are adding a LABA LAMA. At the top of that, we are adding an ICF. We don't have much of options with us, but that is where the medicine is going, that we need to start, categorizing into different subsets. This is again the fast decliner. They have more than 60 ml of drop in FE1 every yearly, and they have been measured by serial PFTs. Again, this have a worse prognosis. Then overlap asthma, where they are generally younger age. They have asthma in their childhood, but probably because of smoking or because of something else, they develop a asthma COPD overlap. They respond better than the normal COPDs on ICS and OCS. And then whenever they have an exacerbation, you have a very good response to OCS. So that is what the way forward is, that we need to categorize each patient into each phenotype and then see how we can move from a stratified medicine to a personalized medicine. What we have been doing in asthma. Now with the advent of biologics, we have started using more and more biologics. We are trying to phenotype a patient into whether it is eosinophil predominant, whether it is, IG mediated, depending on the TH1, TH2, whether this patient would be a good candidate for an biological therapy or not. The same way, we need to move forward in that direction, that not all COPD patients are the same. We need to figure out which phenotype will work better, and we need to ultimately go into a personalized medicine. So this is the gist of the entire talk that I'm trying to talk about. So till now, we know that patients who had no exacerbations, we have been giving more or less long-acting bronchodilators. Overlap also, we have been giving inhaled corticosteroids, but more and more patients who had started developing exacerbations with chronic bronchitis, we start using mucolytics, we start using PDE4 inhibitors, and we start using macrolides, which is, which patients to be using this is the crux of the matter that we need to start thinking about later on. So coming to the conclusion of the first part, COPD is a complex disease. We need to understand that it's a complexity. It's better to provide better care to our patients. And it is a heterogeneous disease, not one size fits all. You cannot treat each patient of COPD in the same way. And current reductionist approach, that is, treat all patients based on the airflow limitation, is absolutely not the way forward. We need to individualize the patient and give personalized care. Coming to the second part of the topic, that is gold grouping, that everyone must be aware about. So I'll run quickly through it. We all know that based on the FEV1 values, when the patient is having a lower FEV1 by FEC ratio that is less than 0.7, we classify gold guidelines into gold 1, 2, 3, 4. One is where it is mild, it is FEV1 is more than 80%, moderate is 50 to 80%, severe is less than 30 to 50%, and very severe is less than 30%. And then we have a MRC scale, again, grade 0 to grade 4, where 0 is I'm just getting breathless on during exertion, during strenuous activities, and grade 4 is when I'm too breathless to even, dress or undress or go out of the house. This is a CAT assessment which we have to do for every patient who walks into the clinic, because now, depending on the ABCD grouping, we have to individualize our treatment and change the treatment. So this CAT assessment score is a very simple score. They have 8 questions. The patient is given a questionnaire. In my OPD, right outside the reception, only a patient of COPD is given this questionnaire. They just tick marks. So you understand what is the scoring on that. So anything which the patient is having more symptoms, you realize that probably the patient needs more care, more probably an ICS, more inflammatory, anti-inflammatory agents can be added depending on what is the symptom level like. So now this is the latest gold guidelines. What you have seen is that initially the grading, that is the spirometry grading, was incorporated into the ABCD guidelines, but now it's a separate entity altogether. You just confirm the diagnosis, assess, then you just grade that 1, 2, 3, 4. But this ABCD guideline, ABCD scoring is independent of the spirometry values. So A is where you have less risk and less symptoms. B is where you have more symptoms and less risk, and so on and so forth. So A, B, C, D, and D is the worst, where you have more or two or more exacerbations, or more exacerbations leading to hospitalization. And the lower part is lower panel is only exacerbation is having 0 to 1. Exacerbations means moderate or major exacerbations, where moderate is where you require an antibiotic or a steroids, or major is when require emergency visit or hospitalization. And MRC grading and CAT scoring more than 10, CAT score or MRC score more than 2, you label it as group B or D depending on that. And this is how the treatment changes. I'm not going to go into the treatment aspect of that. And with that, I'll end my topic today with a very simple saying. If you do what you have always been doing, you'll always get what you have always gotten. So you need to change ahead. You need to do more of personalized care. Thank you, everyone, for a very patient hearing. And thank you for the earlier speakers. If any comments, more than welcome.
Yeah, I think we have time for a few questions here.
Yes, sir.
I'll put it across to you. This is from Delhi on Dr. Pranav. Shouldn't we treat asymptomatic smokers with normal spirometry? Symptomatic smokers with normal spirometry? If yes, which drug has no guidelines here? Lama, Saba combination.
So yeah, so there is no guidelines to say that. Probably the first foremost is would be to make the patient quit smoking. That would be more than the most important thing.
More
Apart from
okay.
that, the most important thing, what I would probably do is just keep the patient on close monitoring. Probably repeat the spirometry in 3 months or 6 months time. If the patient is asymptomatic, that would be the case. If the patient is symptomatic, then there's no question about it. We directly start on treatment. That would be how I would approach the case.
And there's another question. FEV1 by FEC versus FEV1 by FEV6, the newer ratio. Can't it underestimate obstruction? As the FEC value higher than FE6 can get reduced ratio earlier.
Yes, I think Dr. Salil would like to
Yeah, so
comment on that.
even the first question, I'll just add to that. Since the person is a symptomatic smoker, probably there would be a difficult decision whether not to or to treat it. So I think with symptomatic, as you said, we should be going ahead with the treatment. The ratio FEV1 upon FV6, can't it underestimate the obstruction? So yes, that is the hitch, and that's why we don't have those standardized parameters to talk about it as in the guideline. But as different studies will come in and we'll be able to standardize it, I think that time we will be able to have this as an important parameter. But I think you made one comment earlier that in cases with COE or COPD, we may not be able to have that cutoff. And the FBC may be for a longer duration. It may be 12 seconds or 11 seconds. But if you correlate it, whatever the observation is that if the ratio is less than 0.75% and he's symptomatic or exposure to smoke, then we should be considering it as early sign of a COPD.
Correct.
Yeah, one more question. Any biomarkers to differentiate endotypes of COPD?
So again, what I was going across the previous slides. So what you see is it has been still under studies. What they have found is in people who are smokers, they have more WBC count is higher. What they have is TNF alpha is surprisingly higher, and couple of other biomarkers which are higher in COPD patients. But when they saw the subset of patients who developed actually a COPD, not the same markers were elevated. So there is something else which we really don't know, but we have understood one thing. Then the patient develops a COPD, lot of biomarkers are elevated. So probably we need to target those biomarkers in which patient it is getting elevated, and whether any specific anti-therapy for that particular biomarker would ultimately help the patient to have a better quality of life.
Fair enough.
Here, I feel we should be also considering the overlap where we called asthma COPD overlap, where the eosinophilic component is as a biomarker in people with exacerbators or having underlying COPD or phenol levels which are significantly high in COPD patients. Maybe those are the ones where we can take them as a biomarker towards inflammatory phenotype and have a inhaled corticosteroid as a backbone of therapy in that particular subset in terms of biomarkers.
So asthma COPD has always been known that when you have an higher eosinophil, you have generally more response to inhaled corticosteroid.
You categorize eosinophil counts of more than 300 and less than 100.
Correct.
I mean, that would probably dictate the choice of drugs that you're going to use in an individual.
Correct.
Okay. Now, I think the questions from outside are done there. And any questions in the audience here, please? Questions, comments, any clarifications that you require? I think, yeah, we're keeping on time. I think that leaves us enough time for discussion also. I think Jeenam did a wonderful job in giving an overview of the entire phenotypes and how you categorize, how you tailor make your prescriptions for an individual. And it's not so simple. You have to consider so many factors before you start writing a prescription. Giving a prescription is just a simple part of the treatment. The major part is how you're going to counsel him, how you're going to make him stop smoking, how to get out of the environmental factors which are causing the problem, and how to start off on pulmonary rehab at that very early stage. Don't wait for him to really become sick before he goes in for pulmonary rehab. I think these are such important things that nobody talks about them, but I think we need to stress that. And I'm sure he would be doing that for all his patients. So I think there's a senior pulmonologist here. Any comments, sir? Okay. Yeah, I think we can go on to the next speaker. Is going to be online. Dr. Shawn or Aaaron. Yeah. Yeah, we're just trying to link up and put him on the line. Just give us a few minutes, please. Jeenam, you can come and take your place.
Hi, can you see me? Hello?
Hello, yes, Dr. Aaron, you are audible. You may please share your screen presentation.
Yeah, okay. Okay, thank you for inviting me, and thank you to BMJ for sponsoring this presentation. I'd like to wish everybody in India a happy Diwali, and I hope you've all enjoyed your holiday. I'm going to be speaking about prevention of COPD exacerbations, and I'll specifically be reviewing the evidence behind or supporting what we might do to try to prevent our patients from having exacerbations. So the objective of this talk will be to review the burden of COPD exacerbations in the population. We'll then review important studies that have focused on preventing COPD exacerbations. And finally, we'll try to integrate results of studies of new drugs, as well as non-pharmacologic therapy, to decide where to position interventions to prevent exacerbations of COPD in our patients. Now, the first thing, you probably have seen this paper, but if you haven't, I think you have to be aware of it, that there is a new definition of COPD exacerbation that is being proposed. And this is the Rome proposal. This definition has not actually been validated yet, but it's in the process of being validated in the near future. But this new definition, which was only published several months ago, says that in a patient with COPD, an exacerbation is an event that is characterized by shortness of breath or cough or sputum that worsens within a period of 14 days, which may also be accompanied by systemic symptoms such as tachypnea, tachycardia, and is often associated with increased local and systemic inflammation caused by airway infection, pollution, or other insults to the airways. So this is a more inclusive definition of COPD exacerbation that doesn't depend on the treatment that the patient receives. The old definitions were often included, the old definition of COPD exacerbation said it's a patient who develops worsening cough or shortness of breath or sputum who is treated with prednisone or antibiotics. This definition takes the treatment out of the equation and simply discusses the symptoms as well as the systemic manifestations and the inflammatory manifestations that accompany COPD exacerbation. And this is why patients have exacerbations of COPD. On the left, you'll see the causes of acute exacerbations, and they usually stem from infection, either with bacteria or viruses, and at least 50% of COPD exacerbations are due to infection, or potentially pollution. And the speaker before me, or one of the speakers before, spoke about indoor air pollution and exposure to biomass fuels. All of these things can trigger an inflammatory burst at the level of the airway. And when the airway becomes infected, either with viruses or bacteria, or exposed to irritants such as pollutions or potentially allergens, you then get this airway inflammatory burst, which causes increased mucosal edema within the airway, which can cause increased mucus production in the airway, and which of course can be associated with smooth muscle constriction around the airway. And then that leads to physiologic derangements, which then provoke the symptoms of COPD exacerbation. And this was studied really well in a study with Dennis O'Donnell that we did several years ago, where he very elegantly showed that during exacerbations, we get worsening inflammatory insults to the airway, which lead to an acute worsening of airflow obstruction, which then leads to dynamic hyperinflation and air trapping. And this creates an increased end expiratory lung volume, which ultimately manifests in an increased residual volume, and finally a reduction in inspiratory capacity. So basically what's happening in a COPD exacerbation is these patients are developing worsening airflow obstruction, which then leads to dynamic hyperinflation. And as they become more and more tachypnic, they worsen their air trapping, and they basically create this impaired inspiratory capacity, and it's impaired IC, which then approaches the TLC and causes dyspnea. So basically, bottom line is you're getting worsening airway inflammation, worsening air trapping, which is resulting in significant dyspnea, and that leads the patient to present to the healthcare provider. This was a very large study looking at the natural history of COPD exacerbation. It's called the ECLIPSE study. They followed over 2,100 COPD patients for 3 years. And the bottom line is that the best single predictor of future exacerbations is a history of previous exacerbations. So that if your patient has had 2 or more exacerbations in the last year, they're more likely to have an exacerbation in the upcoming year. And the ECLIPSE study also showed that people who have worse gold stage COPD are more prone to exacerbations. So as you go from gold stage 2 COPD to gold stage 3 and gold stage 4, this is just based on airflow obstruction. Patients are much more likely to be hospitalized for an exacerbation and to have more than 1 exacerbation per year, which is sort of intuitive. The worse you start off at, the more likely you are to have trouble in the future. Now, the effects of frequent exacerbations on patient outcomes are multiple. And this is just a summary slide. I'm not going to present all the data, but this is a summary slide that talks about the effects of frequent exacerbations on patients. Patients with 2 or more exacerbations a year have poor health-related quality of life. They have increased inflammatory markers, both within their airways and systemically. They have faster decline in lung function over time. They have higher rates of cardiovascular mortality and morbidity. They have higher hospital readmission rates, and they have increased all-cause mortality. So it's clear that there are numerous bad patient outcomes associated with frequent COPD exacerbations, and therefore preventing COPD exacerbations should be one of the goals of care when we treat our patients with COPD. And this is a study that shows all-cause mortality in patients who have had frequent exacerbations, that is exacerbations and serious exacerbations. These are exacerbations that require a visit to the emergency department or a hospitalization. And you can see in the red line are the group that had 3 or more serious exacerbations per year, and the green line are the group that had no exacerbations in the previous year. And you can see that all-cause mortality is dramatically worse in the group that had 3 or more serious exacerbations in the previous year. And in fact, if you look at survival to 5 years, which is the end of the graph at 60 months, you'll see that the group that has had 3 or more exacerbations in a year has an overall 5-year survival of less than 30%. So these people, frequent serious exacerbations are basically a biomarker of accelerated risk for mortality. Now, the big question is, can we prevent COPD exacerbations, and can we prevent COPD hospitalizations? And I'm going to show you in the next few minutes that we can. There are various strategies, some of them that are less sexy than others because they just involve preventative care and immunizations, but these strategies can definitely prevent exacerbations. And then there are treatment strategies with pharmacologic therapy that can prevent exacerbations. And I'm going to show you in the next few minutes how all 5 of these interventions will prevent exacerbations. And we're going to start by recalling, and this is a Canadian COPD guidelines that were published only a few years ago. You'll see that the Canadian guidelines state that no matter how severe the patient is, whether they have mild lung function impairment or severe lung function impairment, whether they have a low CAT score indicating mild symptoms or a high CAT score indicating severe symptoms, you start on the yellow box. So the key to COPD therapy for all patients, regardless of severity, is to do self-management education, to promote smoking cessation, to encourage activity and exercise, to make sure these patients are vaccinated against COVID, flu, and pneumococcus. And as a first step, in someone with very mild symptoms, you could start with short-acting bronchodilators. Clearly, as the patients progress and become more severe, you would add other therapies, including inhaled long-acting therapies. But the point of this slide is to show that the yellow box is talking about non-pharmacologic therapy, which is just as important as pharmacologic therapy to treat COPD. And so we'll discuss non-pharmacologic management to prevent exacerbations first. Smoking cessation is probably the single most effective intervention you can do in your office to reduce the risk of patients developing COPD, and it's the only intervention that has been shown to slow progression of COPD. However, I want to add a caveat to this statement. There are no smoking cessation trials that have actually examined rates of acute exacerbations of COPD as an outcome. So I can't tell you for sure that getting a patient to stop smoking will decrease their rates of COPD exacerbation, but it is almost intuitive that it will, because it will prevent COPD from developing and worsening over time. And we have studies that go back to the 1990s that show clearly that if you can get a patient to quit smoking, they will arrest their decline in lung function. And this is the lung health study, which was published back in the 1990s and updated in 2002, when they looked at 11-year outcomes in patients who were able to be sustained quitters or intermittent quitters or continuous smokers. And these patients all started with mild COPD. You'll see at the graph at year 0, their lung function was in 78% of predicted at mean value, FEV1% predicted. So these were not severe patients, but they were smokers. And they managed to get about a third of the patients to quit smoking throughout the rest of the 11-year follow-up. And you could see that those who quit actually improved their lung function transiently and stopped declining their lung function at an accelerated rate. Whereas those who were unable to quit after 11 years had lost more than 12% more FEV1 compared to the group that were sustained quitters. So quitting smoking is the most important thing you can do for your patients, and encouraging them to quit and providing them with guidance on how to quit and pharmacotherapy to help them quit will definitely improve their health outcomes and presumably also prevent future exacerbations of COPD. Another very standard and preventative treatment to prevent COPD is vaccination. And when this study came out, they looked at vaccination for pneumonia and influenza, but I imagine future studies will lump vaccination for pneumonia, influenza, and coronavirus together. We don't have this coronavirus data yet, but this was an old study that came out in 1999, but clearly showed how vaccination for pneumonia and influenza can prevent hospitalizations within the community. And what we're seeing here in the blue line is the unvaccinated group, and in the green line is the group that had been vaccinated for pneumonia and influenza. And you can see there are peaks and valleys of hospitalizations for pneumonia and influenza. And in the Northern Hemisphere, the peaks occur during the winter and the fall season when viral season is rampant. And you can see during these peak times, which are labeled INF1 and INF2 and INF3, the group that was vaccinated against pneumonia and influenza was protected against hospitalization, whereas the group that was unvaccinated was not. And this is data from one of my colleagues, Dr. Sunita Mopuru in Ottawa. She analyzed, this is pre-COVID data, she analyzed data from over 5 years in 4,000 Canadian patients who were hospitalized with COPD exacerbation. And they did NP swabs and did multiplex testing for influenza and other respiratory viruses. And the multiplex PCR testing showed that 18% of hospitalized Canadian patients with COPD were likely developed their COPD exacerbation because of acute influenza A or influenza B infection. And she also showed that in those who had influenza-related hospitalizations, you could enact a 38% reduction in these hospitalizations if you were vaccinated against influenza compared to unvaccinated COPD subjects. So it's clear that influenza vaccine, which should happen yearly in the fall months around now, will protect patients with COPD from coming into hospital with acute COPD exacerbations. So we've talked about smoking cessation. We've talked about vaccination strategies. The other question is, can we intervene early in acute COPD exacerbations, and will this improve outcomes? And I'll show you a few studies which show that that this is a useful strategy to try to prevent severe exacerbations of COPD. First of all, just to give you a bit of background, studies in North American and also, I believe, Indian emergency departments have shown that if you delay treatment of acute COPD exacerbation, this is associated with an increased risk of hospitalization. And this was a study that showed that patients who delayed presenting to the emergency room with the COPD exacerbation symptoms had a twofold increased risk of hospital admission. So it's clear that you want to try to treat COPD early to try to prevent hospital admissions. And this is another study from a British group that showed that delay between onset of COPD exacerbation and the delay between onset of symptoms of COPD exacerbation and treatment is associated with a longer recovery time. And you can see on that graph, the x-axis shows delay between symptom onset and treatment, and the y-axis shows the symptom recovery time, and there's a direct relationship. So the longer you wait to get treatment, the more likely you are to delay your recovery time. So it's clear that early interventions might be useful to prevent severe exacerbations of COPD. And studies have suggested that prompt therapy of acute COPD exacerbation is associated with quicker recovery and fewer hospitalizations. We have done studies that show that about half of exacerbations begin suddenly. In other words, you have less than 24 hours from when the patient starts developing worsening respiratory symptoms to the point where they actually descend into a COPD exacerbation. And so this suggests that if you only have 24 hours to act, that clearly providing patients with self-management action plans and pre-specified action plan prescriptions for antibiotics and steroids could be appropriate for some patients. Just like we use action plans for asthma and give people prescriptions for prednisone or oral steroids to prevent worsening exacerbations, we can do the same for COPD. And this was a Canadian study that is now almost 20 years old, but was quite dramatic in its outcome. They randomized 191 patients with COPD to self-management group or usual care. And the self-management group had access to a nurse on the telephone, and they were given COPD action plans with prescriptions for antibiotics and oral steroids for home use. And they were also given instructions on when to start antibiotics and oral steroids. And they showed over the course of a year that there was a 40% improvement in hospitalizations and ED visits in the group that got the self-management plan compared to the group that got usual care. So self-management with home treatment can reduce ED visits and hospitalizations. And the same results were found in a second study that was done in the United States several years later, a larger study where they randomized 743 patients to a brief education session and a COPD action plan and monthly phone calls. And they had the same outcome as the first study, and they showed the same thing, a 41% reduction in ED visits and hospitalizations for patients with COPD who were in the self-management disease arm. So this is a very good strategy that can improve outcomes. In the interest of fairness, I want to tell you about one study that showed that self-management could be dangerous. This was a study that was published by an American group in 2012, and they provided patients with a brief educational program, written action plans, and access to case managers by telephone. And their primary outcome was COPD hospitalizations. Now, this study, unlike the other ones, showed no difference in the time to COPD hospitalization. Furthermore, it actually showed a poor survival difference in the group that got the intervention, that is the self-management plan. They seemed to die at a greater rate than the group that got usual care. And the thought is in this study is that they really didn't educate the patients very well. And the patients were unfortunately delaying seeking medical care because they thought because they were in the self-management group that they could stay at home much longer. And it's thought that a lot of these patients didn't use their self-management plan and delayed seeking medical care and died at home. So this is one sort of unsettling finding. But if you take the three studies I've shown you, and these are by far the three largest studies of self-management, and you put them together and you look at the cumulative mortality, the cumulative mortality in the usual care group compared to the disease management group is really the same, 9.8% versus 10.2%. In the three studies amalgamated over 1 year. So I don't think there is a real mortality signal if you do a meta-analytic analysis of these three trials. So in conclusion, COPD exacerbations will present suddenly, and disease self-management with action plans and early treatment and education will prevent ED visits and hospitalizations. The next question is, what about your patients with very, very severe COPD? Those patients who have chronic hypercarbic respiratory failure. Can non-invasive home ventilation help these patients? This is one of the pivotal studies that was done in 2017 that looked at home non-invasive BiPAP ventilation with oxygen therapy versus oxygen therapy alone. And they looked at hospital readmission or death after an acute COPD exacerbation. So these were very sick patients. These were people who had been hospitalized in the United States with a COPD exacerbation. And these were patients who had persistent hypercapnia on their arterial blood gas. Their PCO2 was greater than 53 millimeters of mercury several weeks after they were admitted for COPD exacerbation. So they sent these people home. They brought them back 3 or 4 weeks later. They repeated their blood gas. If they were persistently hypercapnic, they randomized them to home oxygen alone, which was the control group, or home oxygen plus non-invasive BiPAP ventilation. And their primary outcome was time to readmission or death over 12 months. The patients underwent an intensive non-invasive ventilation strategy. So they were actually admitted back into hospital for 2 days, and they were followed at nighttime, and their BiPAP pressures were titrated to achieve a significant reduction in their arterial CO2 tension. They tried to normalize the PCO2 in this high pressure ventilation strategy, which meant that they ended up using very high pressures in these people. IPAP settings, mean IPAP setting was 24 centimeters, EPAP setting was 4 centimeters, and they kept them on a backup rate of 14 breaths per minute to make sure that they were really ventilating these people and over-ventilating them at night. And what they were able to find, remember, this was a very sick group who had recently been admitted for COPD exacerbation. They were able to find that the patients that got BiPAP ventilation at night had a longer time to readmission or death compared to the control group. Basically, in the patients who got the intervention with home NIV, the 50%, the time by which 50% of patients were readmitted or died was 4.5 months, whereas in the control group, it was only 1.5 months. So clearly this strategy does work, but again, this is sort of a palliative strategy in your sickest patients. This would not be a strategy you would use for most of your patients with COPD. So in summary, the evidence, this study showed a positive effect on time to readmission and death. There are a few studies that showed no benefit, but the studies that showed no benefit actually did not use an intensive home ventilation strategy to try to normalize the PCO2. So the study that I've just described to you probably worked because they brought people back into the hospital after the discharge for COPD. They made sure they were still hypercapnic with a PCO2 more than 53. They titrated them in the hospital with an elective inpatient admission, and they brought the patient back for further titrations to try to optimize CO2 removal using a high IPAP strategy. Now, this may not be a strategy that is easy to do in your hospitals. I know in Canada, we cannot bring patients back electively for titration of NIV. We have to do it at home. And obviously we get the computer system to tell us how they're doing at nighttime, but we can't bring them in and have their titration done by respiratory therapists or physicians within the hospital. We just don't have those hospital beds available. And I'm not sure in India if this strategy would work or not. So now we'll shift from non-pharmacologic therapy. We've talked about smoking cessation, we've talked about early intervention, and we've talked about vaccinations and home NIV for our sickest patients. Now we're going to talk about drugs to prevent acute exacerbation of COPD. And in 2020, I co-chaired the ATS document, which was an official ATS, American Thoracic Society, clinical practice guideline on how to pharmacologically manage COPD. And I'm going to talk to you a little bit about what the evidence shows and what we recommended. The first thing is to go over, and I'm not going to go over the trials because I would be here for hours, but the bottom line is that compared to placebo, if you use a monotherapy with a long-acting anticholinergic, such as tiotropium or a similar drug, or you use a long-acting beta-adrenergic bronchodilator, a LABA bronchodilator, like formoterol or salmeterol, compared to placebo, you will decrease exacerbation rates over 1 year by 15%. So long-acting bronchodilators are effective as monotherapy to decrease exacerbation rates. The next message is that if you use a dual ICS LABA in all comers and you compare it to placebo, you will achieve a 20% reduction in acute exacerbations compared to placebo. If you use a dual LABA-LAMA bronchodilator and you compare it to monotherapy with either a LABA alone or a LAMA alone, the dual LABA-LAMA bronchodilator treatment will similarly reduce risk of exacerbation by 20%. And I'm just showing you in red, this is data that we compiled in our ATS clinical practice guideline. There were 15 studies that studied the dual LABA-LAMA against a LABA or a LAMA alone, and the relative risk reduction versus monotherapy was, the rate ratio was 0.80, which translates into a 20% risk reduction in COPD exacerbations, and that was statistically significant. So we know that LABAs work, LAMAs work, ICS LABAs work, and LABA-LAMAs work. They all work to decrease COPD exacerbations. And I think most of our patients are on some combination of these drugs. The next big question is, what about triple therapy? Triple therapy means therapy with an inhaled steroid, a LABA, and a LAMA. And the IMPACT study is one that came out recently that studied this. They studied over 10,000 patients with acute exacerbations of COPD. They had to have at least one moderate or severe exacerbation in the last year. And if they were only gold stage 2 COPD, they had to have at least 2 moderate or severe exacerbations or 1 severe exacerbation in the last year. So they were taking people with frequent exacerbations with moderate or severe COPD, and they were randomized them to either a LABA-LAMA, an ICS-LABA, or triple therapy, and they followed them for 1 year, and their primary outcome was COPD exacerbations. And this is what the IMPACT study showed. Triple therapy in patients who have a history of frequent exacerbations is better than an ICS-LABA or a LABA-LAMA at reducing exacerbations. So what you can see here in the navy bar that on the left, that's the triple therapy with the Trelegy product, which is an ICS, LABA, and LAMA. And the rate of annual exacerbations is 0.91. There was a 15% reduction compared to the ICS LABA in light blue. And there was a 25% reduction in exacerbations compared to the LABA-LAMA in dark red. The only important thing to recognize here is that there seems to be a differential effect. That one of the speakers was talking about phenotyping our patients with COPD. It looks like blood eosinophil count is a phenotypic marker that can predict response to inhaled steroids and hence predict response to triple therapy in people with COPD. So the bottom line is, in the patients who had blood eosinophils of less than 150, there was no significant exacerbation difference in those who got triple therapy versus the LABA-LAMA. But in those who had a blood eosinophil count at baseline of 150 eosinophils per millimeter cubed or greater, there was a significant effect favoring the triple therapy with a 32% risk reduction favoring triple therapy over a LABA-LAMA. So it looks like blood eosinophils can be a phenotypic marker that can tell you which patients are going to respond most effectively to inhaled steroids. And this is a second trial which looked at a different triple therapy. This was the Ethos trial, a different company with a different product, but did the same thing. They took people with frequent exacerbations and moderate or severe COPD, and they randomized them to triple therapy versus an ICS-LABA versus a LABA-LAMA, and they followed them for 1 year, and they looked at exacerbation rates, and they showed the same thing as the previous trial, that in patients with moderate or severe COPD with a history of frequent exacerbations, you achieve a better reduction in exacerbations using the triple therapy compared to using either the ICS-LABA or the LABA-LAMA. The triple therapy here is in burgundy in the middle, and you can see they have fewer exacerbations compared to the ICS-LABA on the right in dark blue, or compared to the LABA-LAMA on the left in green. And again, they showed, this is very consistent data from two large clinical trials, that the group that showed the benefit were the patients with high blood eosinophils. You can see on this axis, on this graph, where blood eosinophil counts are on the x-axis, and the rate of moderate or severe exacerbations are on the y, that the group that in green that got the LABA-LAMA, if these patients had a blood eosinophil count of 200 or greater, they were much more likely to exacerbate on a LABA-LAMA compared to patients with a blood eosinophil count of 200 or greater who got triple therapy. So it's clear that the inhaled steroid is working in those people who have blood eosinophil counts somewhere in the range of 200 or greater. So in conclusion, the IMPACT and Ethos trials both met their primary outcome. They showed that triple therapy decreases rate of exacerbations to a greater extent than an ICS-LABA or LABA-LAMA. And this was in patients with moderate or severe exacerbations with a history of frequent exacerbations. They also showed that patients, the subgroup with blood eosinophils of 150 or greater, seemed to drive the primary outcome. So the ATS guidelines suggested, based on this data, that we suggested the use of triple therapy in patients with a history of one or more exacerbations in the past year who have had at least one moderate or severe exacerbation requiring antibiotics or steroids. We concluded this. Some of you might know that inhaled steroids and COPD are associated with pneumonia. So some people might say, well, why do you want to recommend a treatment with inhaled steroid triple therapy in people with COPD if we know they're going to get more pneumonias? we actually did the math and did a meta-analysis of 8,000 subjects in clinical trials. And we showed that if you give triple therapy, the patients experience 15 more pneumonias per 1,000 patients, but they also experience 230 fewer COPD exacerbations per 1,000 patients. Therefore, the math clearly favors triple therapy in people with a history of frequent exacerbations. And the benefits of triple therapy outweigh the risks. And I'm not going to show you the data, but there is data now to also suggest that in people with moderate or severe COPD exacerbations and moderate or severe COPD and frequent exacerbations, that triple therapy also has a mortality benefit of about 0.8% to 1% per year. So it looks like if you prescribe triple therapy to these people, they may be less likely to die. So who do I treat with triple therapy? I treat people with COPD exacerbations who have one or more exacerbations in the last year, despite being on an ICS LABA or a LABA-LAMA. And I treat people who have a history of perhaps asthma COPD overlap. That is, people who developed asthma at a younger age and then developed COPD after years of smoking. I will assume they have some component of asthma, and I'll treat them also with either ICS LABA, combination therapy, or triple therapy. I'll include an ICS in these people. Another question you might ask is, who should you withdraw the ICS from on triple therapy? And there are several trials, 2 trials specifically, that have looked at this. This is the most famous trial, called the Wisdom trial. And they looked at withdrawal of ICS in people who were on triple therapy. That is, they withdrew them from triple therapy to an ICS LABA. To a LABA-LAMA, to a LABA-LAMA. And what they showed is over 1 year, there was no difference in moderate or severe exacerbations in the group that was withdrawn off the ICS to the LABA-LAMA. But they did actually show that severe exacerbations were a little higher in the group that were withdrawn. And the hazard ratio is 1.20, meaning there was a 20% greater chance of a severe exacerbation in the group that got the withdrawal of therapy. And you can see by the confidence interval there of 0.98 to 1.48 that almost, but not quite, hits statistical significance. So, one thing you can worry about here is, yes, I can perhaps withdraw ICS safely, but the patient may be at slightly higher risk of a severe COPD exacerbation in the next year after withdrawal. And the other thing that they did show when you withdraw the ICS is you get a consistent drop in the FEV1 of somewhere between 50 and 60 mils over the course of the year. So you could see the group in dotted lines that continued the ICS and triple therapy versus the group that went to the LABA-LAMA. And you see the group that gets the LABA-LAMA does decline their FEV1 slightly. And then there was another trial published called the Sunset trial that looked at this as well, where they took people off. These were people who had no real history of exacerbations. They had less than 1 exacerbation per year in the last year, and they withdrew them off triple therapy or to double therapy with indacaterol glycopyrronium, or they kept them on triple therapy. They found no difference in the total rate of exacerbations, but they did find that patients who had blood eosinophil counts of 300 or higher did much worse, so that the relative risk of exacerbation in the group that had a blood eosinophil count of 300 or higher was 1.86, meaning an 86% greater risk of exacerbations in those who withdrew off the ICS versus those who stayed on the triple therapy. So we're getting a sense here that you don't want to withdraw ICS in patients who have elevated blood eosinophils. And this was confirmed in an analysis of the Wisdom trial, which showed the same thing. People with an ICS, with a blood eosinophil count of 300 or higher, who were withdrawn off triple therapy, had a greatly increased risk of exacerbations over the next year. And this is basically showing you the graph, in the middle, I don't have a pointer here, but the patients who had 300 eosinophils or more had a rate ratio of 1.56. That is a 56% greater risk of exacerbation in the next year if they were withdrawn. So who should you not withdraw inhaled steroids from? You should not withdraw inhaled steroids from patients with COPD who you think also have asthma as well. So if you think they have asthma COPD overlap, they have a history of asthma in childhood or young adulthood, I don't withdraw the inhaled steroid. You should not withdraw inhaled steroids from patients with COPD who have bloody eosinophil counts of 300 or greater. If you do, they're more at risk for exacerbations in the next year. And I personally, although there's no evidence for this, patients with very severe COPD with a low baseline FEV1 of 600 mils or less, I don't withdraw them off the inhaled steroid because I'm worried that they won't tolerate losing 50 more mils of FEV1 when the steroid is withdrawn. What other treatments can we do to prevent exacerbation? There's no question that azithromycin given in a dose of 250 milligrams once a day for 1 year will prevent exacerbations in people with a history of COPD exacerbation. This was a large US study that was published more than 10 years ago that showed that patients given azithromycin had a prolonged exacerbation-free period in the year compared to those who were given placebo. And if you look at the frequency of exacerbations, there was a 19% reduction in exacerbations in those who were given azithromycin every day compared to those who were given placebo plus usual therapy. So you can reduce exacerbations using azithromycin. You have to be aware, of course, that there are several side effects that you have to be watched for. One is azithromycin in the long term can cause potential hearing loss. It can prolong the QT interval, so you don't want to give it to someone who has a long QT on their baseline ECG. And the other thing is, and I didn't write it in the slide, but I should have, that you don't want to give it to someone who's chronically infected with non-tuberculous mycobacteria. So if you are treating someone with COPD with azithromycin, it's a good idea to get a sputum culture before you start and an ECG before you start. The sputum culture is to ensure they don't have NTM, and the ECG is to ensure they don't have a prolonged QT interval at baseline. And in those patients, you would not treat with azithromycin. Roflumilast is a PDE4 inhibitor. It works only in patients who have a chronic bronchitic phenotype. That is, they have to have chronic cough and phlegm production and frequent exacerbations. But in this group, it can decrease acute COPD exacerbations by 17% over a year. So I only give it to those people who have frequent severe exacerbations and who have chronic cough and phlegm. The thing you have to remember about using roflumilast, it has a lot of GI side effects. It can cause nausea, vomiting, diarrhea, and weight loss. So it's very good in your overweight patients and your obese patients, because they will lose on average 4 to 5 kilos over a year on roflumilast. I would not give roflumilast to a thin patient with COPD because they won't tolerate the GI side effects and the weight loss. But in your classic chronic bronchitics who are overweight, who have chronic cough and phlegm, it's a potentially effective drug as long as they tolerate the side effects. So this is my second to last slide. This is, I didn't talk about all these interventions, but I'll go over them very briefly and tell you which drugs prevent acute exacerbation of COPD and which have been proven in clinical trials to be effective. So influenza has been confirmed to be effective in clinical trials. Pneumococcal vaccine, although I recommend it in all my patients, has actually not been confirmed to be effective to prevent acute exacerbations of COPD, but it sure isn't going to hurt. So I give it to all my patients. LAMAs work, 15% reduction against placebo. LABAs work, 15% reduction against placebo. LABA-LAMAs work both against placebo and against individual monotherapies with LAMA or LABA. ICS-LABA works as well. I've already shown you data that triple therapy in some patients is better than treatment with double therapy in those who have severe or moderate COPD, who have frequent exacerbations, or who have bloody eosinophilia. Azithromycin works in addition to triple therapy. If the patient continues to have exacerbations, I'll put them on azithromycin once a day. I'll use roflumilast as well in people who have chronic bronchitic phenotype and are overweight. We did a big trial of simvastatin over 1 year, and it was not effective, so I would not use statins to try to prevent COPD exacerbation. Pulse moxifloxacin was not shown to be effective. Vitamin D is not effective, so I don't use that. And N-acetylcysteine is sort of a drug that still needs to be proven. It has shown some efficacy in preventing acute exacerbations of COPD, but the issue is that most of the patients in the trials are from China, and many of them were being undertreated at baseline. Many of them were only on theophylline, which we don't use for COPD in the Western Hemisphere. And then they add N-acetylcysteine added or placebo. We don't know that N-acetylcysteine will work when it's combined with usual optimal care, such as using triple. Does N-acetylcysteine work when added to triple therapy? We don't have those trials. How do I treat my patients? I give all patients vaccinations. If they're smoking, I give them smoking cessation counseling and pharmacotherapy to get them to quit. I give most of them an action plan and COPD education so that they can recognize acute exacerbations and treat them early if they have symptoms of an acute exacerbation. If they have less than 1 exacerbation a year, I treat them with a LABA/LAMA. But if they have blood eosinophilia of 300 or greater, I will treat them instead of a LABA/LAMA, I'll give them triple therapy. And if they have more than 1 exacerbation per year, on average, I will treat them with triple therapy. Whether or not they have eosinophilia, I'll give them triple therapy. If they still experience frequent exacerbations on triple therapy, I'll add in azithromycin. And if they're still experiencing exacerbations and they have a chronic bronchitis phenotype and a BMI of 25 or greater, then I'll consider adding in roflumilast. I believe that's the end of the talk, and I'll be happy to take questions.
I think that was a very lucid presentation. I think the management of exacerbations has been put in a very clear perspective. And I think everybody should have got a very clear idea as what is to be done in patients with severe COPD, using the triple regimen, using azithromycin, using vaccinations. Almost all these things are, they form the standard of care. And I think we should adhere to these things. I think we're going to have a session wherein it's an open house where anybody could ask questions, and I'm sure we're all open for any questions right now. Yeah. Request Bendre and Jeenam, come now.
I have some questions. If you have any questions, want to ask directly, they're open. If you want to pen down your questions, and I will go first.
I think this is a question for Dr. Aaaron. For how long do you prefer giving azithromycin when we say long term? Is there a definite period which may be considered?
Yeah, well, the trial used 1 year of azithromycin daily. So I will put the patient on azithromycin for a year, and I will monitor them during that year and make sure they don't have any adverse effects of the azithromycin, but also see if I've decreased their exacerbation rate compared to the year before. And if they do have a positive effect after 1 year, that is fewer exacerbations and maybe feeling better, I will leave them on the azithromycin long-term indefinitely. If they have no effect after a year, I stop.
Okay, then the next question, does LAMA/LABA/ACS improve outcomes in AECOPD? I think that was made pretty clear in the talk itself. So I think this question can be ignored right now. Dr. Benhard Joel says, a brief insight on PRISM.
Pardon me, I missed that question. I'm sorry, can you repeat it?
A brief insight on PRISM.
Oh, PRISM. Well, PRISM is preserved spirometry, preserved but impaired spirometry. So PRISM is when you see a patient who has an FEV1 less than 80% of predicted, but their FEV1 to FVC ratio is normal so they don't have obstructive lung disease based on current spirometry. We didn't talk about PRISM in this talk, but studies have shown that if you do longitudinal follow-up forward of patients with PRISM, that a significant percent, about 20 to 30%, will go on to develop spirometry that's consistent with COPD. So PRISM may be an early spirometric indicator of COPD in some people, but we don't have any clinical trials that have looked at treating PRISM. So I can't really give you any recommendations on how to treat it at this point because we don't know.
All right. There's another question called risk of pneumonia in patients with triple combination therapy.
Yeah, there is a risk. I showed you the slide where it's about 15 to 18 excess pneumonias per 1,000 patients. But as we discussed, the risk of acute COPD exacerbation is 250 exacerbations per 1,000 patients. So if you do the math, the bad risk of pneumonia with triple therapy is outweighed by the good effects at decreasing exacerbation. And although I didn't show you the data, there were 2 studies that have come out in the last year that suggest they're both from the impact and the ethos study. When they looked at mortality, all-cause mortality as the primary outcome, they showed about a 1% absolute benefit in all-cause mortality in patients treated with triple therapy. So even if these people are getting pneumonia, it doesn't look like they're dying with pneumonia. Triple therapy is keeping them alive longer. So I wouldn't worry too much about the risk of pneumonia.
Hello. Yeah, one question I wanted to ask is, in your experience, have you seen COPD patients and OSA? And if yes, then how much is the prevalence of sleep apnea in our COPD patients?
Well, that's a good question. That's called overlap syndrome. They call it COPD OSA overlap syndrome. I want to be honest, the research is there, it's been published, but I don't know the number. I don't know what percent of our severe COPD patients have OSA. I would have to look that up, but it's definitely published. I know that. One of my colleagues in Ottawa, Dr. Konzerska, just published a paper on that, but I just don't have the number in my head. I don't know if you have any data on that.
I really don't have the data, but I think it is getting underdiagnosed. There is a significant number of patients who are labeled as COPD, treated as COPD, but without any evaluation of sleep apnea in them.
Oh, absolutely, absolutely. My recollection is at least 20 to 30% of patients with moderate and severe COPD have sleep apnea when you test them using polysomnography. So I totally agree with you. We're missing that comorbidity in a lot of our patients.
I think I have another one here. If the sputum eosinophil count is more than 300 and I have started on LABA and LAMA and ICS and the level comes down below 300 after a few months, do we need to stop ICS?
Yeah, we don't know. I mean, we don't know. I wouldn't stop the ICS because the trials looked at, the trials that looked at withdrawal of ICS looked at the baseline blood eosinophil count the day they started the study. And they showed that if your baseline blood eosinophil count was 300 and you withdrew the ICS, you're more likely to exacerbate. So in the patient you're describing in your question, I would not withdraw the ICS. I would keep them on the triple therapy.
Now, this question is directed to you again. If you use triple therapy in exacerbations of more than 1 per year, that would mean all group B COPD on triple therapy. But GOLD gives 3 options: single, double, triple therapy. Your comments.
Yeah, I mean, I think that GOLD needs to be updated. We have a lot more information that's come out in the last year with the ethos trial and the impact trial, and it's clearly showing benefit. I think GOLD needs some updating, and the reason GOLD is, it's just that all this literature has just come out, so they haven't updated yet to indicate. I think eventually in the next year or two, you'll see that the clear indications for triple therapy will be any patient with COPD who has more than one exacerbation on average per year, or patients with bloody eosinophil of 300 or greater.
Okay, I will pass on this question to Dr. Bendre. Experience with Vilanterol in COPD, safety of anticholinergics and LABA-C cardiovascular disease.
So Vilanterol, yes, we have been using since the time it has been launched in India, and it is found to be safe. It's a once a day dosage, so convenient for the patients. And over here, we have got a combination of long-acting steroid, inhaled corticosteroid, and inhaled bronchodilator. So yes, in patients who have got hyperreactivity, we have used it. But if you speak specifically for COPD, there is an insistence of using a LABA, LAMA, and a ICS because we have to use anti-muscarinic medication or a bronchodilator when there is a predominant COPD. No, that's okay. I think people heard it. Yeah.
Yeah, I'll just add on to that point. In Indian patients, compliance is a big issue. So giving them multiple inhalers in a day becomes a big challenge. So if you have a triple combination, which is in a single inhaler or a single DPI format, definitely be much better for our patients. We can, give a once a daily dose for all three together.
Yeah, I think this point was made very clear by Dr. Aaron also, that most of the patients, especially people with a higher eosinophil count, they all do well with this triple therapy. And needlessly, ICS has been blamed for, increasing incidence of pneumonia, which is put very clearly that the benefit that accrues with ICS use offsets any disadvantage of having a pneumonia in the long-term use. Your comments, Dr. Aaron?
Yeah, I agree. I mean, remember, I still use, I don't want you to think I use triple therapy in everyone, right? I mean, if the patient has moderate or severe COPD, but does not have a history of exacerbations and does not have a bloody eosinophil count of 300, I use LABA-LAMA as my first line, and I keep them on LABA-LAMAs. But if they switch their phenotype over time and start having recurrent exacerbation of COPD, that's when I'll stop the LABA-LAMA and put them on triple.
Now, is there any proven role for oral steroids in a case of exacerbation? I think this has already been answered. I think there's a very definite role for oral steroids on a short-term basis. Oral steroids on a long-term basis for COPD management is to be discouraged and surely should not be done. I think this is the consensus of all the pulmonologists who practice this medicine. Then, what's my experience in treating this particular disease? I think it's not about my experience or somebody else's experience. I think doing the right thing. I think all of us do need to work at the preventive aspects of this particular disease. First thing is ensure that everybody just about stops smoking. And it doesn't come very easy. I mean, how to do it is a big question all of us face. And it is a challenge to get a patient to stop smoking. I think that is the most important thing. Now, regarding the evaluation and pharmacotherapy, yeah, it does play a role. Probably, I would say about 30 to 40% role in management of COPD. The non-pharmacological management of COPD is equally important. Somehow, as physicians, we tend to neglect that aspect of it. I think that should be very clearly enunciated and needs to be discussed with the patients about the non-pharmacological management of COPD also. Prevention of smoking and prevention of infections, I mean, having a flu vaccine, having a pneumococcal vaccine, whatever benefit it gives. And all these things definitely play a very, very important role in the management of COPD. I think all the three speakers have emphasized on this particular aspect. And I think more emphasis is actually pointless. That is the role of managing COPD, and that's the right way to do it anyway. Any comments?
Just a question for doctor. So basically, we talk about recurrent exacerbations, severe COPDs, when gold group D. We are always talking about inhaled corticosteroids. But is there any algorithm or is there any thinking behind what amount of dosages of inhaled corticosteroids? Is there any particular way you start off with a higher dose or a lower dose? Is there any consensus on that, or how do you actually decide on that?
Yeah, that's a good question. The consensus is that the lower to moderate doses are just as effective as the high. So, and I'm not sure what drugs are available in India, but in Canada, if I'm using triple therapy, for instance, I would use the 100 microgram formulation of Trelegy, which is 100 micrograms of fluticasone furoate. Not the 200 microgram, which is the asthma dose. Similarly, if I'm using budesonide, I would use either 200 micrograms twice a day, maximum 400 micrograms twice a day for a patient with COPD. So you don't want to go to the high dose ICS because you'll get more side effects and more morbidity with it. And there's no, the studies have shown that high dose is not better than low to middle dose.
Okay, we'll move on to the next question. Can you explain the difference between pre-COPD and early COPD?
Pre-COPD sort of implies that the patient is smoking but doesn't yet meet criteria for airflow obstruction on the spirometry. They were the ones that were years ago called gold zero. So they were at risk for COPD. So that typical smoker who doesn't yet have COPD. And early COPD is hard to define. You know, I don't know how to define early COPD other than to say that it's when you catch someone relatively young who's having symptoms, just starting to have symptoms, who has relatively mild airflow obstruction on their flow volume curve. But I'm not really sure we have a good definition for early.
Okay. I think we have had a very fruitful session of over 2 hours with good speakers covering almost all the aspects of COPD. And I think during the discussion, the importance of prevention of COPD has also been highlighted. So after all this, I think we are at the conclusion of the session. And now I'll hand it over to Dr. Simi Kaul to make the concluding remarks. And at the outset, let me thank BMJ and Lupin for facilitating this meet here with an excellent talks. Thank you very much, all of you.
All our faculty, I think needless to say, Professor Shawn, our chairperson, Dr. Jayachandra, Dr. Salil, Bendre, and Dr. Jeenam, Shah. It was a wonderful, wonderful experience for all of us. And thank you to all the delegates for sparing time, especially over the weekend. We understand and we really appreciate that. We'd like to know how your experience has been. How's your academic expectation? Have you met that? For that, we'll request you to scan the QR code which is kept on your table. It's a very short 30 seconds of feedback. It'll help us improve your future experience with BMJ Masterclasses. In case you have any query with regard to product and services which is offered by BMJ, British Medical Journal, please write to marketing.india@bmj.com. And for next 30 minutes, we are here. If you have any questions, you can please reach out to us. We'd like to thank Lupin for the support they have given in this. With this, Team BMJ signing off, and I'd like to call Pranali for the concluding remark. Thank you so much.
So thank you, Dr. Simi. Honorable faculty, all the delegates present here and equally virtually, I, on behalf of Lupin Respira, extend my profound and sincere gratitude for sparing your invaluable time. I must say the session has been very interactive and very enriching under the aegis of BMG. We are sure all the 3 sessions have put forward a meaningful insight to your practice. We had presence of 250 delegates at across 7 centers and 375 delegates joining us virtually. I thank Dr. Shawn, Aaaron, Dr. Jayachandra for your excellent moderation, Dr. Jeenam, Shah, Dr. Salil, Bendre for your excellent Indian context on the topics today. And lastly, and most importantly, I would like to thank Hirakos sir for a powerhouse for ideation and a visionary in shaping the respiratory in Indian pharma market. Thank you, BMJ team, for partnering with us and to put up a great show. We look forward for bringing such enriching programs in coming times. Finally, let me thank our sales team for facilitating and the technical team for facilitating the technical arrangements. Thank you, everyone. And have a nice good night. Thank you, sir.
Getting them.